My name is John Sather. I'm the Director of Quality at Yale's Department of Emergency Medicine. Andrew Taylor is going to come up and talk to you for the second half of this. He's the Director of Informatics for our department. And we're going to talk about finding, measuring, and doing something with diagnostic error. And I'll start a little bit by, first I'll get through the acknowledgements. Some of the work we're going to talk about has been supported by an MCIC risk reduction grant that we received last year. No disclosures, and this is kind of the fruition of the work of many people in our department. We give them credit. I'll start by talking about our experience, because it probably mirrors a lot of the academic emergency departments that you're coming from. Yale now is a multi-site health plan that has 3 emergency departments within the purview of our actual administration section. We see about 170,000 visits over those 3 EDs. And actually some of the IT support broadens out to a much larger range of hospitals. Andrew will talk a little bit about that at the end. So I think probably the experience we have is fairly typical for some of the bigger academic emergency centers out there. Our work really started about 2 to 3 years ago when we really had some institutional support for our not only administrative work, but in particular our safety and quality work. Prior to then, it was really just a 1 to 2 man or woman show without a whole lot of IT support, not a lot of resources dedicated to it. And Yale New Haven Health kind of made a mission to change that across the institution, but really the focus on the emergency department. And at that time, we decided it was a good opportunity to sort of look at what we were doing, how effective it was, and where we wanted to go. And we did that in the context of the 6 domains of quality from the IOM. And I would say, like most institutions, we actually probably, when you look at our QI program, we're just focusing on the top 3. Really was the care, safe, timely, and effective. We kind of siloed out a little bit of the other domains, which I think, as we are learning, might be a little bit of a mistake. We have a patient experience director who works closely with the hospital in terms of patient experience, and efficiency is really still in the domain of our operational folks within the administration section. We work closely with them, but I don't think it informs our quality and safety work as much as it can. Clearly, as we talk about diagnostic error, I think we realize that all 6 of these domains are at play. And if we want to fix it and change it, we're probably going to need to recognize that. I want to spend just a little bit of time highlighting the efficiency piece, because as we're doing the work that we're doing, we're realizing that it's really hard to talk about diagnostic error, improving things, without appreciating the relationship it has to efficiency in the department. So this, when we started out with this revitalization of our QI program, was kind of what our dashboard, our scorecards, our reporting system looked like. And it's probably what a lot of the academic emergency departments have in some capacity. We have a safety side, which focuses on things like medication errors, procedural complications, falls, hand hygiene, CAUTI. And then we have, I think, what fits in that effectiveness, timeliness, and overlaps with safety domain. And your typical things, sepsis, STEMI, stroke, intubations, there's others, but that's sort of a general idea. And the real question is, where does diagnostic error live? In our department, it really didn't have a fixed metric. It didn't have a fixed way of reporting it out. I think in many ways, some of the things we report on are almost predicated on the fact that we made the diagnosis. So we know that we have septic shock. Let's see how we manage it and how effective we are because we made the diagnosis. We don't have a great idea of when we're missing that diagnosis. And I think, as you all know, this is a big push, I think, in healthcare in general, that idea that diagnostic error is lurking, we're not doing a great job measuring it, and it can have a significant impact. So clearly it's on our radar, and I think it's on everybody's radar. The real problem, I think, as we started looking into it, was what we construed to be perhaps an ineffective conceptual model. So again, this is what we were doing, and I suspect it is reflective of what's going on in other academic emergency departments. But we really were looking essentially at the totality of diagnostic opportunity, and then we would screen them by whatever triggers were available to us. And then we kind of came up with a random pattern of diagnostic errors that didn't really have a place to live. These are the kind of triggers that we use. Again, probably some of the triggers you're using. 72-hour returns, mortality review, any escalations within 24 hours we look at, referrals from risk management or legal, patient relation referral, clinician referral, and incident reporting. The challenge there is overall, either they're super time consuming and the yield isn't great, or they're not that time consuming, but they're low frequency events. So usually when we hear about a diagnostic miss from legal or risk management, it's probably pretty real, well worth our look. But those are far and few between, thankfully. The other ones I think that we spend tons of time sifting through the charts, trying to find error, and unfortunately I think don't come up with any meaningful pattern or pattern recognition that informs our performance improvement. And so what it ends up being is we often notify our clinicians or our healthcare team if it's a system-wide issue. That's often delayed. It's taken us a while to sift through all those charts. And these events are sporadic, so it's really hard to capture pattern recognition, hard to tell our clinicians or the system, hey, we're seeing a recurrent problem. It usually is perceived as a one-off and gets from either the system or the clinician what I call the shrug factor, where they either say, yeah, that was a miss, but I can't catch them all, or error is part of what I do. And ultimately, what we were seeing as we really try to look at that is that performance improvement with respect to diagnostic error was more of a, hey, let's just try harder next time. Say some of the systems things we pick up when we review error sometimes have more impact on a system level, but really trying to reach our clinicians, sort of have them identify where there may be some problems and correct that, really challenging under the current conceptual model. So we knew we had to change. We knew it was on everybody's mind. A lot of people want to change, but we really didn't have a whole lot of guidance. And so we sort of took the IHI model for improvement and said, let's really refine what are we trying to accomplish with this with respect to diagnostic error? How are we going to know a change if we see one as an improvement? And what can we do? What levers can we push once we figure out some of the patterns to result in an improvement? And so I think it's really important to recognize when talking about diagnostic error that maybe even that is the wrong term and maybe the wrong focus. When we would go to our clinicians and say, hey, you missed one, oftentimes there was a commentary about, well, I can't work everybody up to that degree to find that entity, or, you know, I'm not going to scan everybody because that has downstream effects, so that's not the type of practitioner I am. And I think there's some truth to that. So these three elements come together in what I call cognitive pressures on the clinician who's at the forefront about to make an error or not. And really what we want to measure, if we can, is not so much diagnostic error, but diagnostic safety. And I think that necessitates an appreciation of all three of these data streams. And that becomes a little bit more challenging. So it made us change our conceptual model a little bit. And so what we propose to do is, rather than looking at the totality of all diagnostic opportunities, try to look at the totality of diagnostic opportunities for a specific diagnosis, find the times that we miss that diagnosis, and then define our error rate for that diagnosis. And in fact, we really don't even want to call it a diagnostic error because we're not quite sure it's truly an area. We just know it's a diagnostic miss. And then if we can put that through a funnel that incorporates some data that speaks to resource utilization per the system or per the provider, in addition to throughput, which is another competing cognitive pressure, then we might come up with a more meaningful diagnostic safety score that would allow us to actually drive some performance improvement. So when we talked about how to get to these measures, again, we sort of looked at the basic tenets of characteristics of good measures. We knew we had to be important. These had to be high priority areas where measurement of a problem would have a high impact, or else we weren't going to get buy-in from our clinicians or systems who would be receiving some of this assessment. Needed to be scientifically acceptable, reliable, and valid. Our data had to be good, had to be usable and relevant to our current practice environment, had to be feasible, which is kind of the biggest one. Can we reproduce this? And so what we chose to do for our project, and I'm going to hand this over shortly to Andrew, is we chose, rather than, again, to look at everything, is to pilot a program where we look at 3 specific diagnoses, ones that we think are high priority, can't miss, frequently encountered. So we chose appendicitis, PE, and head bleed. And we like these because, number one, they address sort of a pan-system approach. Obviously, belly pain complaints are addressed here. The approach a clinician or a system might have to working up or evaluating belly pain, chest pain, shortness of breath is addressed with this, and neurologic complaints. So a wide spectrum of chief complaints is addressed with this. All of them have some CT utilization or diagnostic imaging utilization questions, concerns, or even guidelines. One of them in particular, PE, to a lesser extent, head bleed, has an acceptable diagnostic miss rate, which oftentimes in the world of minimizing diagnostic error to zero is not appreciated. So we liked that it kind of fits some of the guidelines out there that says, hey, maybe there are some acceptable misses. So I'm going to hand it over to Andrew to talk about how we're going to get from that sort of conceptualization of this to something that we can then turn into a real performance improvement tool.
Any questions while we transition? Okay, so I was one of the people that was principally in charge of trying to implement some type of structure that would allow us to be able to do these things. And I think it's first important to talk about what we mean by diagnostic error in this situation. And really, I think it's that there was a missed opportunity to make a diagnosis, regardless of whether the patient had a particular harm that resulted from that miss. And that, I think, is the key point. We're not linking this to a particular harm event that occurred afterwards. So I think the main thing we thought about was like, well, how do you kind of screen and figure out and capture all of these diagnoses that are occurring? And you really can't do it with a traditional type medical record review. It's non-selective. It's extremely onerous. You're going to spend hundreds and hundreds of hours of going through different things, and it's extremely resource intensive because of that. So we looked at using EHR triggers, which enable like a targeted review of a few high-risk patients, which we kind of had mentioned before. A nice thing about them is that you can look at it both retrospectively. So even though we're implementing this now, we can go back and look at our system performance over the last couple of years because we'll have that data within the system. And then you can also integrate a prospective component as well. The problem with EHR triggers right now is a lot of them have rarely moved out of kind of the research environment, and probably some of that is due to kind of the implementation tasks that it takes. So this is kind of our diagnostic error kind of IT pipeline, and I'm going to go through each one of these individual components, but I'll just kind of start and just give you a brief overview of them. And I know the individual elements on here are small, but basically, we're starting with identification of the diagnoses, and that's system-wide. And then we look back in time to see whether there was some related ED visit associated with that diagnosis. Once we find those, that goes through kind of a quality improvement review that you still have to have some type of chart review, and then we create quality dashboards out of that. And I'll go through each of the individual components as far as the IT stuff. So for the identification of diagnoses, we tended to focus on diagnoses that we could confirm, I would say, have a really good gold standard associated with them. So we used a combination of both ICD codes and then also radiology reports, mostly CT and MRI for these three particular diagnoses. And what we did with this is so we kind of queried the entire EHR database, looking for ICD codes that were associated with pulmonary embolism. And then in addition to that, we pulled out all of the impressions from radiology notes and then used natural language processing on top of that to identify the diagnoses within those impressions. Because I'm not convinced, and you shouldn't be convinced either, that you can identify all of the diagnoses from just ICD codes. So this was kind of an additional support structure on top of that. We then move those into new tables, kind of refine them, and finally identify all of the diagnoses that are happening within the system itself. So this is just an example of kind of what the NLP looks like. It's just basically, it's going through, I won't belabor the kind of algorithms and everything else, but we're basically identifying unstructured data and pulling out kind of components within that. So, okay, so now we've identified all of the, potentially all of the diagnoses for like pulmonary embolism that are happening within the system. So then what we do is we look back in time, and we had some discussions about how much time do you need to look back for any particular diagnosis, and it definitely changed a little bit with each diagnosis to see whether there was an ED visit that occurred prior to that diagnosis happening. So for pulmonary embolism, we look back 8 days, and then for that individual visit, we then look and see whether there were signs and symptoms that would have been suggestive of a PE within that visit itself. So for PE, it would be like chest pain, shortness of breath, tachycardia, etc. From an IT implementation standpoint, how are we doing that? So we're going through the notes. We pull out the individual components, like chest pains, for instance, using the kind of NLP pipeline. In addition, we're pulling out like chief complaint components, some more structured data within that, and then we move that into our databases and process that to eventually get to a kind of a labeling of those visits as yes, no, it looks like it was associated with symptoms that might have been suggestive of a PE. So at that point, you've now identified prior visits that were associated with a miss with a diagnosis that happened in the future that had some signs and symptoms that may have been associated with that diagnosis. Then I think at this point you really, to make the final kind of yes no a diagnostic error, you really have to go down to kind of a review by clinicians of those individual charts. But what this does is it allows you to be able to filter from tens of thousands of diagnoses and to prior thousands of ED visits down to a select number of charts that then you can do the QI process through. We also are building the data entry form so that we, when we do the QI process, that data is put into our data warehouse that will then link with all the rest of the data so that we can inform our dashboards and leverage that data to get appropriate analytic analysis stuff out of it. And then we build dashboards on top of that that are going to be updated monthly, that will have the ability to be drilled down into both the ED kind of system level and also at the provider level and by diagnosis as well. So what is this? What's the intent of all of this? It's kind of to promote the situational awareness of diagnostic error within our department, both at the system level and at the provider level. And that's by providing these dashboards that give feedback on both of those levels. And then, I think the other thing that you can do is that as you do operational changes moving into the future, you've implemented something that's supposed to change flow within the department, you can see whether that's changing your diagnostic error rate over the long term, and maybe that you need to change something. So just an example of how you would create a potential kind of feedback mechanism for the individual provider. So this has 3 different components. There's a CT utilization component, a diagnostic error rate component, and an ED length of stay component. So you get kind of an overall feeling for how that physician is performing for a particular kind of either chief complaint or diagnosis. And then you have some type of scoring system, and we haven't really worked out the weighting and everything else that would occur within that to generate some type of score so that physician could kind of get an overall sense of their kind of diagnostic safety performance. And then this also applies to at the system level. So we would get some type of overall diagnostic error rate for a particular for a particular diagnosis. So like for PE, it would be like 1.7%. But then you're also going to have your other performance metrics that are associated with that, and then your utilization rate for CT in general. And then you would put that out over time, so you have all of your time series stuff, and you can see how you're changing from an organizational standpoint. So, what are the limitations of this? I think ours is based on ICD codes and imaging reports. So, the fact that it's doesn't incorporate things like labs and other things where those diagnoses might show up, for instance, like hyperkalemia, you're going to have to think about how you would address those issues if you're moving into those types of diagnoses. It's, at least our system right now is dependent upon some natural language processing. I think that most systems like this in the future are going to be like that, but I do think that increasingly overall healthcare institutions are using natural language processing, and it will only become easier in the future. And again, we talked a little bit about the weighting of the components of the safety score. It's a little unclear to me, what of those three components, the utilization rate, your kind of flow metrics through, your diagnostic error, should they be weighted differently? Some people might argue that you should weight the diagnostic error heavily and then the other two not so much. And I don't think that that's very clear at this point. And so, I think one of the really nice things about this and moving forward in the future is that it scales well. So what we're doing right now is by we're essentially going through all imaging reports, and we're kind of pulling out all of the entities and the within those reports, and so it doesn't take much effort to move from PEs to fractures to other things like that. So you can think about really scaling out to a lot of diagnoses, which I think is where you'll get your kind of bang for your buck. And then triangulating that with other metrics. So again, talking about like flow and throughput and everything else, and feeling whether you're actually making the right decisions with regards to some of those operational changes. And seeing whether they kind of impact your diagnostic safety kind of score within that space. So I think that is it. We'll open it up for questions. I'm not sure exactly the time. It's probably pretty close to. Sure, go ahead.
Thanks for the presentation.
Oh, yeah, sure.
The big challenge, I think, with this topic is creating an environment in which it's okay to make errors as long as you learn from them. And I was wondering if you guys had any strategies for how to create a culture in which when you send out that email to the provider saying, hey, this is a potential error and an opportunity for improvement, the response isn't, well, I can't catch them all, I can't scan everybody.
Yeah, so I think that is a great question. I think probably what drove us to this point. And if you take PE for an example, I think what we're currently doing now, this isn't up and running and it's not live with the clinicians, but we'll come up with a case where we missed a PE and we'll let the doc know, hey, you missed a PE. And the doc will say, well, I know I missed the PE, but I'm your best throughput guy and I never use CTs like my neighbor who scans everybody. So I think I'm a better doc. And missing PEs are okay. There's some truth to some of that. There's some non-truth to that. And without any kind of measurement, we can't speak to it. So it kind of falls right there. That's it. And unless there's the diagnostic error that is just so overwhelmingly egregious. But that is such a tiny portion of what we do. And we're talking about kind of moving the needle towards a safer environment. I think it has to be done like this. And I think when you start presenting data like this that respects sort of those cognitive pressures those clinicians feel and acknowledges that error or a miss is okay. It's what we do. We can learn from it. I think is important. Some of the other things that I think are really interesting we've talked about, we didn't really have time to put it in here. I've had docs say to me, well, fine, I missed that PE because I was on that one shift of the day where when I show up for work, they immediately put 20 patients in my area. So I'm running around crazy seeing all those patients. And I said, well, that sounds pretty reasonable for you to be concerned, but I have no metric, no data to support that. So it'd be really interesting to triangulate. Once we get this up and running and say, you know what, there's some truth to that. We're seeing more of these misses for these key diagnoses when we're in this one area where the volume patient per hour is high. I think some of what our docs are saying is true. And I think when you build a performance improvement program like that that kind of respects those cognitive pressures and the realities, you get a lot more buy-in.
I was just going to say about that. I mean, I think whatever I applaud you guys for adding the throughput and utilization. So I think it really is a balance between utilization of testing and misses, right? None of us are perfect. The diagnostic tests are not perfect. So your miss rate is never going to be zero. So I guess my question is, do you guys have like a target goal in mind in terms of your diagnostic miss rate for these diagnoses?
Well, some of it's guided by the literature. And so PE is a nice one where we have kind of a rough yardstick. Doesn't take out the egregious, how did you miss that PE? But you didn't apply the scoring system well, or you didn't have the right pretest probability assessment. What we've looked at from an operational standpoint, we've actually borrowed a little bit. So when we do our operational metrics, and that's not what we do, Andrew provides a lot of the data, but we look at moving the needle, and we look at the bell-shaped curve and kind of taking the outliers and moving them towards the middle. So rather than having a, you're never going to miss a PE, and we don't want you to, I think that's not realistic. But if we're able to do this with some degree of replicability and validity, we can say, look, your partner who's working the same number of shifts, same number of patients per hour, missed 1 PE last year. You missed 5, and your CT utilization's no lower or higher than his or hers. I think we may have a little bit of a problem. What can we do to help you out? And I think that has a lot more buy-in from the clinician when you've really appreciated the realities, other than say, hey, you missed a PE. Good question.
I had a similar, well, somewhat similar project, trying to, with similar methodology. And I always ran into the problem that there weren't enough cases to really draw conclusions or figure out trends. And I was like, gosh, I need like 20 times the number. I looked at 30,000 children one time and all the adverse events that happened. So I'm like, I need like 20 times this number. I was wondering if you guys had the same problem.
I think you're right. So I think that's the critical aspect about this is scaling up to multiple diagnoses so that you do start getting the numbers. I think from a organizational standpoint, you probably can present data on just PEs and other stuff within the organization. You probably have a few misses every year, 10, 15 from an organization. It depends also how big your organization is. But to really get down and kind of nail down to the individual providers and start to see stuff, I think you really need to kind of scale up to a lot of diagnoses so that you're covering more of a larger percentage of what that provider is seeing overall. So I would agree. I think it's a tough task moving forward. I think it's nice that we have we see lots and lots of patients. We have a huge organization, but for a much smaller organization, I think that would be difficult.
Maybe more value to the system in general when we're done with this than to say, hey, it wasn't so effective with the provider, although we sort of did our due diligence, but for our entire ED system to know how many PEs we missed, what our CT utilization rate, and what our throughput, that may have some more meaning when we bring 170,000 visits per year and look at it over a number of years.
Well, the one trend that I found was kind of frustrating. It was like essentially people who were like long-term care facilities and like had kind of like not so aggressive care plans moving forward were the big misses. And you're like, oh, well, that makes sense. I don't know if that's
No.
No.
We haven't done enough yet with this. This is conceptual. To really to say what our lessons are. We'll come back maybe next year and tell you what we really learned from it.
My question to you, and this is something that's come up in our forum meetings, is how important is it for the ED physician to make the diagnosis? Because a lot of times we admit someone for shortness of breath or for fever, and we don't know exactly what the outcome is. And I think a lot of us would argue that that's not our primary job if we stabilize the patient that we're in. So I like the idea of diagnostic safety instead of diagnostic error, because I don't think it's always our goal to 100% correct. And a lot of things, for appendicitis especially, our job may be to send someone home and tell them to come back with the pain migrates to the regular form.
So there was a piece maybe a little bit buried in there. First of all, we struggle with the same thing. We have a peer review committee that meets every Thursday and goes over cases, and this is the endless debate. Was that an error? Was that an acceptable miss? Is it okay to send an appendicitis home? And I think the general idea, at least from my perspective, if you wrote on the chart, hey, I think it could be appendicitis, but I'm going to send them home to watch, and they know to come back if it's worse, and they come back, we wouldn't call that a miss. So there's a lot of challenges there. But there's the piece where we take all this sort of data. It kind of gives us a much better glimpse into that big pool of diagnostic opportunity. It still needs to go through a peer review committee in a process where the humans look at it and say, the variables weren't there. I think it was, although we didn't diagnose the PE, we were worried about it. We needed to give some steroids because of a contrast allergy for the CT, and there was a bleeding risk, so we didn't heparinize them, but we admitted them knowing that it could be that. That's fine. The human sort of assessment there.
Hi, Dan Mayer, also from Albany. I wanted to thank you guys for doing this project. I think that the Institute of Medicine has said that that diagnostic error is the most common cause of death, and I have absolutely no idea where those data actually really came from. Certainly, I think we see diagnostic error all the time. We're all human. We all make it. And it's great to see see that you guys are looking at trying to identify it sort of upfront before it becomes a complaint or, well, in some cases it's going to be a bad outcome. I just wanted to say that there are a lot of the work in diagnostic error up to now has been sort of focused on trying to prevent diagnostic error using debiasing techniques or other ways of changing our cognition, and then of course looking at the systems issue in the ED with multitasking and interruptions, constant interruptions in our workflow. And I just add that tomorrow afternoon I'm going to be leading a session with a group from Ohio and Michigan on how do you teach prevention of diagnostic errors. So I'm not sure if we're going in the right direction or if you're going in the right direction or if we're both coming at it.
Well, they go hand in hand. Actually, I spent a lot of my time actually teaching in the medical school on metacognition and sort of approaching prevention of diagnostic error just from those things that you talk about. I think what we're actually getting towards, if we could, with this diagnostic safety score, have some of the outliers in, say, our department who seem to be outliers, to then have them go through something like that with a more direct approach. And I think that's sort of the holy grail, to find where people need help with performance improvement and then provide those strategies. I agree with you, completely key.
Great. Well, I hope that you'll come to our session tomorrow at 3:05. Sorry, shameless promotion.
No, it's fine.
Well, thank you, everybody.
Thank you all.
Appreciate it.